Hi everybody, this is Margie, and I'm actually recording from Dr. Wright's office up at the George Washington University campus. It's been an extremely busy day today. We've been in meetings all day, and with Stephanie getting ready to go up for her surgery tomorrow. Wow, we've been trying to go through a lot of stuff, so be looking for an announcement or two from me with some things that we had discussed this evening. Nothing major, and probably pretty much nothing you don't already know, but just wanted to fill you in. So I'm not sure how long this lecture is going to be. I'm going to try 45 minutes so that I don't totally bore you, but it's going to be on hyperlipidemia, and it's for the FNP1 students for the fall of 2009. Okay, the third report of the expert panel on detection, evaluation, and treatment of high blood cholesterol in adults was approved by the National Cholesterol Education Program Coordinating Committee in September 2002. Boy, is that a mouthful. And it's known as ATP III. Now, I know you're going, wow, 2002. Well, they have not come out with anything since then, and these are still the guidelines that we are using today to guide our management of COPD, hyperlipidemia. And the guidelines that we're going to be talking about in the next 45 minutes are primarily from this ATP information because it's the guidelines. You can download this whole report for yourself from the National Cholesterol Education Program, National Heart, Lung, and Blood Institute, National Institutes of Health, NIH publication number 02-05215, September 2002. It's free. I don't know, though. I think I'd send away for a hard copy because to print out the whole thing is going to really run down your computer printer, etc. The differences between ATP3 and ATP2. Yes, there was an ATP2, and I think that you should be aware of some of the differences because it kind of tells you where we've been and where we're going, if you will. And eventually, there'll be, in your lifetime, an ATP4. I can imagine, and you're going to probably be teaching someday down the road or saying, I remember when ATP3 recommended this. So it's just, this is the way it goes. ATP3 is more heavily focused on primary prevention in patients with multiple risk factors. It raised persons with diabetes mellitus without coronary heart disease to the level of coronary heart disease risk equivalent. This will get explained further on in the lecture, and this gets repeated probably too much in this lecture, but I did you guys a big favor because I'm telling you, the ATP3 guidelines, the huge pamphlet from the beginning to end, is the most boring read you'd ever want to read about hyperlipidemia. And it repeats the same information almost in every single section. It was extremely frustrating for me to tease out what I felt was the important information for you. So just ignore it. If I repeated it way too many times, probably just expect it to be a test question, and I'm sorry. What they did as well is they used the Framingham projection of a 10-year absolute coronary heart disease risk. And what this is the percent possibility of having a coronary event within 10 years. All right, to identify certain patients with multiple 2+ risk factors for more intensive treatment. This will make sense to you a little bit further on in the lecture as well. And it also identified persons with multiple metabolic risk factors as candidates for intensified therapeutic lifestyle changes. The Framingham Heart Study, you probably are all familiar with this study, but just in case you aren't, I felt like I needed to explain this study a little bit to you because if I tell you to go ahead and look up on it and read, you're too busy to really just go and see what this is all about if you're not already familiar with it. And throughout your careers as nurse practitioners, you're going to hear physicians, nurse practitioners, references that you read, articles that you read, always referring to this Framingham Heart Study. This study was conducted in Framingham, Massachusetts. It started in 1948, And it's a very famous study where they began to identify the common factors that contribute to cardiovascular disease over a long period of time in a very large group of participants. They had 5,209 patients, male and female, between the ages of 30 and 62. And what they did was brought them on in for a complete physical examination, lifestyle interviews, etc. And they were looking for common patterns of who develops coronary vascular disease, and they were looking for the patterns in that. And this is how this whole research on coronary heart disease really started. In 1971, they bring these patients back every 2 years. Okay, as long as they're alive, every 2 years they continue to come back and get a complete physical to see where they're at and another lifestyle interview. They did this every 2 years, and then in 1971, they enrolled like the second line of patients, the second generation of patients, again, another 5,000 roughly patients. And then in 1994, there was a new study with more culturally diverse patients. And so they changed this thing overall to try to keep up with the research as it's developing over a period of time. And in April of 2000 and, is that April, what are we, this is 2009, 2002 I believe, was the last time or the most recent time that they know, 2009 I think, that they started to get some more patients in. But anyway, and the Framingham study proved that those with higher cholesterol levels have more atherosclerosis. That Framingham proved that, so we know that. It also showed that coronary heart disease relationship between serum cholesterol and coronary heart disease is proven. The relationship is high cholesterol equals more people with coronary heart disease. Incidence of coronary heart disease is proportional to serum total cholesterol and LDL levels. When the remember LDL, we'll get into this, is low density lipoprotein. And the LDL, with the L, we want low, okay? Low, less than 100 milligrams per deciliter is optimal, even in the presence of other risk factors. Cardiac heart disease is low. So this relationship between LDL and coronary heart disease has been proven. It's very interesting to also note that people who migrate from areas of low cholesterol to populations of higher cholesterol raise their cholesterol levels as they acculturate into our country and develop more coronary heart disease. So we know that has a lot to do with our lifestyle, our eating patterns, our physical activity patterns, our fast food, and things of this nature. So we know part of this is very cultural. And in patient populations who have an overall average cholesterol less than 150, which is low, we like to see cholesterol under 200. So if you've got a cholesterol less than 150, that's awesome. And an LDL less than 100 is also awesome. And they've also proven that these individuals have little to no coronary heart disease. Oops. Okay, well, let's talk a little bit about pathophysiology. What are we talking about here? We're talking about cholesterol. We're talking about lipids. We're talking about fats. Our cell membranes, as you can remember, are made up of fats, of lipids. And lipids are needed, okay? So we need some cholesterol. They make steroid hormones and bile acids, all right? Lipids circulate in the serum with proteins, and that's why they're called lipoproteins. There's three main types of lipids. Your low-density lipoproteins, or your LDL, and overall 60 to 70% of your cholesterol is LDL cholesterol. Okay, and we want to keep that low. It's the bad cholesterol. High-density lipoproteins, H for high, all right, we want high. Okay, and 20 to 30% of your HDL, of your overall cholesterol is HDL. And we like to see that greater than 40. All right, and then there's the very low density lipoproteins, or the VLDL, and that includes the triglycerides, and that encompasses about 10 to 15% of our overall cholesterol. Lipids in the blood are influenced by diet, obesity, drugs, and genetics. And we know that. And you have to remember that our body makes cholesterol as well as our exogenous intake of it, if you will. Primary hyperlipoproteinemias are either due to a single gene disorder or to multifactorial disorders. And the one thing I want you to remember about that is there's genetic component in some individuals with hyperlipidemia, and it usually presents early on, if you will. Secondary hyperlipoproteinemias can be thyroid disorders and diabetes mellitus, which it occurs as a part of a constellation in certain metabolic pathways. Okay? And you often see when your patients come into the clinic, it's a really good guess if you say, I call it the clinical triad. Almost all the patients that I see that have hypertension have diabetes and hyperlipidemia as well, and vice versa. You usually see those three run together. Secondary dyslipidemia is all around an increased LDL cholesterol level. And what it means by secondary is you need to look at an underlying cause. Often these people have high blood pressure, diabetes, as I just mentioned. Maybe they have hypothyroidism, nephrotic syndrome, a liver disease, because if they have obstructive liver disease, the liver makes the cholesterol, so that's going to be a player. Chronic renal failure, certain drugs such as progestins, anabolic steroids, and protease inhibitors that are used to treat HIV patients, they can be all causes of secondary dyslipidemia. So I don't talk too much about this throughout the lecture because we're talking about hyperlipidemia and how you treat it. Treating an underlying cause, you're going to think about these things as necessary. If they don't respond to your treatment, if they don't respond to lifestyle changes, if they don't, if they're out there exercising and they're doing great with their diet and they've lost weight and they've done the things, which are very rare that your patients are going to do the things that they need to do, okay? These are the things to look for secondary dyslipidemia. You'd get a urinalysis. If that shows you proteinuria, then you know you've got some sort of nephrotic or chronic renal failure or something going on in the kidneys. Obviously, if you want to say, I wonder about hypothyroidism, you'd get a TSH. If you suspect that, well, geez, I wonder if this patient has an underlying diabetes mellitus, well, go ahead and draw a hemoglobin A1C. Normal is, less than 7, and certainly if you draw it and, you can make that's not how we make a diagnosis, by the way. Actually, you could get a hemoglobin A1C, but if you want to diagnose diabetes mellitus, you get a fasting AM blood sugar, and if it's greater than 126 times 2, they have diabetes. And alk phosphatase, if you want to go ahead and order one of those, or just an overall liver function panel, because you can get your AST, your ALT, alk phos as part of that panel. It detects biliary disease. Atherosclerosis is the systemic disease that occurs when lipids are deposited within the blood vessels. Now, you know that, I know. And these changes and those lipids are what we're talking about today. So I get into some graphics a little bit down here because this is what I show my patients when they just don't understand. Sometimes people are visual people, and if you show them a picture, they get it. Whereas they don't get the words or they don't hear what you're having to say. So there's different ways to get patient education across to your patients. And atherosclerosis changes can lead to stroke, peripheral vascular disease, coronary artery disease, and myocardial infarction. I thought these were some interesting facts. 1/3 of all patients with MIs die within 24 hours. So if you haven't had an MI lecture yet, or you have, I'm still, coming on with this course as far as when you get all this stuff. Interesting that 1/3 of your patients are going to die, no matter what goes on, within 24 hours of them having their event. 1/3 of all new cardiovascular events occur in individuals less than 65 years old. And it's getting younger and younger and younger. We're seeing more cardiovascular events in younger people as our nation gets bigger and fatter and more sedentary. 2/3 of individuals who suffer from the first major coronary event occur greater than 65 years old, and that's their first major coronary event, okay? Aggressive LDL lowering is effective in reducing coronary heart disease. This is going to be repeated over and over and over again. This is your target, LDL. I mean, you know, if you see that on the exam, you're looking for the LDL in most cases, with certain exceptions, okay? And we'll cover them down the road. And the problem is here, these events occur greater than 65 years old, and Medicare, you know, most often doesn't cover these prescription medicines, so the patients aren't going to take them. The evidence does show the power of elevated LDL to cause coronary heart disease, and it's shown most clearly in persons with genetic forms of hyperlipidemia, because you're going to see that, say, they're young people in their 20s that have genetic hyperlipidemia at a very, very young age, and you're going to see in these individuals that coronary heart disease is going to develop even in the absence of other risk factors. So these people will get it irregardless of that they're not obese, they do not have high blood pressure, and things of that nature. That is why we recommend cholesterol screening at 20 years old and every 5 years thereafter. Unless they've got the genetic form, then you're going to be more aggressive with these individuals. But most 20-year-olds are not going to have the genetic form. And so if their lipid panel looks good in 5 years, we'll do another fasting lipid panel with them. Epidemiology studies suggest that beginning to lower the cholesterol levels at an earlier age will lead to a greater risk reduction than starting later in life. So, for example, a 10% reduction in serum cholesterol level attained at age 40, okay? So you have someone at age 40 who's relatively young, and they're younger than me. I'd like to be 40 again. If they have hyperlipidemia, and you start lifestyle therapy with them, and they reduce their reduction of serum cholesterol by 10%, okay, they're reduced their coronary heart disease chances by 50%. So it's great. But if they're 70 years old and they have a 10% reduction, it only reduces by 20%. So it is the earlier, the better. Okay? And let's see. The relationship between LDL and coronary heart disease develops in stages. It's over a period of time with fatty streaks, fibrous plaques, unstable lumen plaques that rupture, and that gives you your angina, your MI, your stroke, and your death. So LDL is a culprit and the target for treatment. And LDL particles interact with platelets and damaged atrial endothelium and smooth muscle cells in the process of plaque formation. Okay, so that's the culprit. They mess with the platelets. Before you know it, you've got plaque building up. Any LDL levels greater than 100 milligrams per deciliter or greater appears to be atherogenic. So in all your patients, we'd like to see their LDL. I tell my patients, we'd like to see it under 100. Okay, and that makes perfect sense to me. This is out of your, I think it's the ACLS book, and I like this picture, and I have a handout because I don't think people just understand that. I use this with hyperlipidemia and high blood pressure. Here is your normal, what your normal, say, artery looks like. Okay, nice and clean, and the blood is flowing and there's no obstruction. See, this is a clear lumen, and your blood flows through it. So early plaque formation, you start to get, if you have high LDL cholesterol, you're starting to build up here in the lumen wall some plaque formation. And then you can see as it goes along, you get less and less coronary artery, say, blood flow through these arteries at this particular point due to this plaque formation. Eventually, what's going to happen is this is where you start to get angina. If you've got plaque formation and your heart's over here, and these vessels that are very, damaged are leading into your heart. They're the coronary arteries, and they're supplying your heart with blood and oxygen. And you go jogging or do a fast walk, and you increase your heart rate. Well, what does your heart need? It needs these coronary arteries to dilate to bring you more blood and bring you more oxygen to the heart so that you can meet the increased cardiac output that your heart needs to, meet the body's needs. Well, if you can't dilate your coronary artery because they're clogged with plaque formation, then you're going to get angina or unstable angina. You're going to have chest pain, and that's why these individuals take nitroglycerin, because then what it does is dilate this coronary artery around this plaque formation, and all of a sudden they get relief because they get increased blood flow. Okay? Now, when you're totally blocked like this is what they call a STEM MI. Okay? It is a blockage, and it is the beginning of a myocardial infarction. And you're going to see eventually, I don't have that other slide in, myocardial death. This is optimal, LDL, less than 100. Now, in ATP2, it used to be HDL levels of 35. So, the reason that I think this is important too is, you know now it's 40. You're learning it's 40, and that's great. But you're going to still hear like some of the older physicians or nurse practitioners or that aren't keeping up to date with the research and the literature and the changes, and they may still think 35 is the goal. And that is why you are going to be reading from now until ever, until you're done with clinical practice or teaching, because it's always changing. You always have to go see what's new, what's changed. It's 40, okay? The difference too is lower triglycerol levels overall. There's more emphasis now on keeping triglyceride levels low, and we'll talk more about this later. We don't use this anymore. Many of you do remember this ratio of cholesterol and divided by HDL ratio is a powerful indicator of coronary heart disease risk, and it is subsumed in the Framingham study, and it is used still, but I don't use it. I never really learned about it. I mean, I know about it, and some people do use it, because when I learned, it's LDL is the target. High-density lipoproteins, they act as scavengers, and they remove cholesterol from the peripheral tissues and return it to the liver, okay, which produces a favorable cardioprotective effect. So we like our HDL to be high, and we love our HDL levels to be over 60 now. We like to see them over 40. However, when we talk about later on in this lecture about identifying patients at risk, and there's certain ways that you do that, and if these people have these things, they're at this increased risk. Well, if you have a patient that has an HDL of 65 or 62 or 70, you get to subtract a risk factor from these individuals. And the very low density lipoproteins, they're very small amount, as you recall from the first couple of slides. It's 10 to 15% of overall cholesterol, and they carry triglycerides. And they're unsure about the triglycerides' role in coronary heart disease. I've always learned and remember that triglycerides are identified with pancreatitis, okay, in high doses, and we talk more about that later. Risk factors for coronary heart disease and hyperlipidemia: diabetes mellitus, alcohol intake, because that increases triglycerides. We've talked about genetic abnormalities. There are some drugs, such as oral contraceptions, diuretics, and beta blockers, and increased high cholesterol, LDL. Non-lipid risk factors. Okay, for men, greater than age 45. For women, greater than age 55. It's getting younger and younger, don't you think? Male gender, low HDL levels of less than 35. I'm going to say less than 40. I might have to change that. Premature menopause without estrogen replacement. Family history, this is important, of early coronary heart disease. MI or sudden cardiac death before the age 55 in father or other male first-degree relative. Okay, not necessarily grandpa. Now, before age 65 in mom or a first-degree relative, okay? So, if you have somebody that comes in and you're doing a history on them, and for, hyperlipidemia, diabetes mellitus, coronary heart disease, and all of that. I expect to see a family history of this type, no cardiac events, or early cardiac events in family, such as, and you can be more specific if you'd like, but I'd just like to see that you took a family history of this. Hypertension, obesity, and sedentary lifestyle. Some subjective data. So here we are in our history. A patient comes in. We want to know if there's a history of cardiovascular disease. Like I said, is there high blood pressure? Do you have diabetes? Because a lot of people, if you ask, do you have hyperlipidemia, they'll say no. They maybe don't understand that, or do you have high cholesterol? No. But yet they have those two, so I'm suspecting they do. But if they may not, some people don't, so you go to look. Anyway, when was their last lipid panel? Was it within 5 years? And if they have this, they should have one drawn, even if it's like less than 5 years. And nowadays, are they obese? What's their BMI? This would be a really good history. Family history, like I said. Things like this run in families. If everybody has high cholesterol, the patient probably does too. A list of medications. And this is normal. This is just your normal history. I expect to see this on everybody. Very quickly, out in the margins, a lot of you that are mine anyway are getting feedback back on your journals. I like to see this stuff out in the border. I don't like to see it in narrative. I like to see it out here, quick, so I can flip back in the chart and I can see this quickly. Because they'll say negative for high cholesterol, and then they're on Lipitor. So obviously, they don't know they have high cholesterol, or they don't know what their Lipitor is for. See, so this should just be, like you learned in health assessment, continuous thing that you always do, because patients are poor historians many times. And it would be nice to get a diet and exercise routine, and I am going to just show you a quick way to assess it in regards to cholesterol further on in the program here. And I want to see, are they smoking and are they drinking alcohol? And how much alcohol are they drinking? Physical examination. I think you should be able to do a BMI on a patient in clinic. It's not hard to do. You learned about it hopefully in health assessment and how to assess that. And you take a height and you take a weight and you go to the charts and you figure out a BMI. Anyway, fundoscopic exam, because these are the physical exam findings that are going to be pertinent positives or pertinent negatives, and I would like to see them charted. Premature arcus cornealis. I have a picture of that coming up so you can see what that looks like, because I have seen some of these things and patients who have say they don't have high cholesterol, and then what I want to do is to get a fasting lipid panel. Okay, and then lipemia retinalis is also associated closely with this. Is their thyroid palpable? That's arcus cornealis. You see how that is? That's not exactly normal. Okay, it's a circle, arcus meaning a circle, and it's bluish in nature, or you're going to see some sort of white. I've seen it be fibrous and white tissue that just looks abnormal to me, and I'm like, what is this? And if they have a history of high cholesterol, I want you to look in their eyes, because they may have this, and it would be good for you to see it. I mentioned secondary hyperlipidemia. So, they may not have a thyroid problem, but you may feel a palpable thyroid mass and want to get a TSH. This is one of the times, if this is like a cardiac heart disease appointment, then I might listen to the carotid arteries, because I might hear a bruit. And if I hear a bruit on one side, like a whoo, 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 and I don't on the other, and there's something that I can't quite figure out, I'm going to send them for an ultrasound. You may pick up a blockage of the coronary arteries, send them for the ultrasound, and then they can have a carotid endarterectomy, meaning they'll go in there and clean out the plaque. And you may prevent these patients from having a stroke or a TIA. Cardiac, you're going to want to assess the cardiac, S1, S2, are there any S3s, S4, murmurs, rubs, and gallops, vascular exam. Skin and xanthomas, tendinitis xanthomas. I show you a slide of it because then you can say, oh, that's what that is. And then abdomen, do they have hepatic splenomegaly? That's arcus cornealis. This is like, it's not a very good slide, I'm sorry, but this is an xanthoma of the knee. This is a cholesterol fatty deposit in the knee, and if this patient has high cholesterol and you see that, that's probably what it is. This is another one, okay, of hyperlipidemia. You know, the patient might come in and they say, what is this? And you go, I've seen that somewhere before. You may go get, you know, if they have a history of hyperlipidemia, then you might remember, I wonder if this is one of those lipid things. Go to the derm book and look it up and go, yeah, show the patient a picture. And then this is Tendinous Xan. I have not seen this myself, but after I've seen some slides of this, I probably won't remember, forget it. Okay, ATP III classification of total LDL and cholesterol. Okay, total cholesterol. Under 200 is desirable. Okay, 200 to 239 is borderline, and greater than 240 is high. Now this is overall cholesterol. Some people, if they've not been fasting and they ask for cholesterol, some providers will order just a total cholesterol, because don't do the whole lipid panel. That's a waste of time. And if they're less than 200, they're good to go. They don't have to come on in for a, chances are their LDL and their HDL and triglycerides all are pretty good. So that's enough. But if you get the whole lipid panel, the first thing I look at, I have the whole lipid panel, I look at total cholesterol. If it's under 200, I'm very encouraged. If it's greater than 200, you know, I'm like, okay, they have high cholesterol. Next, I immediately look at the LDL, okay? LDL, we like to see it optimal. I've already told you less than 100. Here, 100 to 129 above optimal, 130 to 159 is borderline high. This is considered high, and this is considered very high. And you're going to see, you're going to go, well, that's easy. And it sort of is, but isn't, according to the guidelines. It's not quite as easy as you might think, because I could just say to you, okay, guys, LDL less than 100, anytime you see that, you go ahead and treat them. Well, not necessarily, and you'll see. Triglycerides. A multivariate analysis did not identify serum triglycerides as an independent risk factor for coronary heart disease. Okay? However, we think we know that there is. Okay? So I'll just say that. And then I'm just going to say to you, when you see a high triglyceride level, you know, if you see a high triglyceride level and they have really high cholesterol and they have really high LDL and really low HDL and really high triglycerides, okay, you're going to go ahead and treat the triglycerides. There's times when you focus on it and you treat it. But most of the time when you see triglyceride levels really high, one is, I think, is he or she a drinker, or are they at risk for pancreatitis? Elevated triglycerides, overweight, obesity, physical inactivity, cigarette smoking, alcohol, all of this, and genetic. Okay, I didn't think I've told you anything new there. HDL, we've already known that it reduces the risk of coronary heart disease, and it's shown, epidemiology data has shown that a 1%, okay, this should be increase. I'm very sorry about that. Okay, if there is a 1% increase in the HDL, okay, it's a 2 to 3% decrease in coronary heart disease risk. Do you understand that? That makes sense if you understand that. I will go back after this lecture and I will change that slide. I got those two mixed up. And low HDL cholesterol levels are an independent risk factor for CHD. And causes of low can be because we've got elevated serum triglycerides, overweight and obesity, all of these other things, okay? It's all intermingled. Less than 40 is optimal, okay? That means, yeah, great, they have a low weight, greater than 40 is optimal. Less than 40 is, it's low. We like it, we want to see it above 40. Greater than 60 is great, okay? And we like it, that's ideal. And then triglycerides, normal, less than 150, borderline high, 150 to 199, high triglycerides above 200 to 499, very high triglycerides are equal to or greater than 500. You should be thinking around here of, oh my gosh, they're being set up for pancreatitis. And if they're around 1,000, we get real aggressive with lowering the triglycerides to prevent them from going into pancreatitis. There's such a thing called arthrogenic dyslipidemia, just to confuse you. And that's because if you have triglycerides greater than 150, which, if you go back there, greater than 150 is borderline high, so why are they high? And an HDL of less than 40, you can make your diagnosis of arthrogenic dyslipidemia. And they probably have metabolic syndrome as well. And what difference does that make? I'm not really 100% sure that it really makes any difference, except ATP III guidelines mention this over and over and over again. And I think we discussed this a little bit further. But the treatment for this type of a syndrome is a little bit different. If the triglycerides are less than 200, we typically do not treat the triglycerides. If a patient has a coronary heart disease or coronary heart disease equivalent, okay, which would be your diabetes is a CHD equivalent, okay, we may want to give consideration to raise the HDL. I'm going over this again, so don't freak out, but fibrates and nicotinic acid are the drugs really of choice to focus on this HDL, okay? And also, fibrates and nicotinic acid and statins are good for triglycerides as well. This makes perfect sense because you know that 10 to 15% of our VLDL, of our total overall cholesterol is VLDL, and triglycerides make this up. So if you have high triglycerides, you're going to have an increased VLDL, okay? And we want to lower the triglycerides, but after we lower the LDL. So that would be a secondary goal. And actually the number one drug is a statin, so we get into that. Metabolic syndrome, you hear a lot about it, and anyway, it's characterized by a constellation of metabolic risk factors in one individual. Overweight or obese, that especially truncal obesity is a huge piece of metabolic syndrome, okay? Sedentary lifestyles, genetics. This adipose around the abdomen impairs tissue responsiveness to insulin, and therefore it also has an impaired fasting glucose levels, okay? You're going to see abdominal obesity, as I stated earlier, hyperlipidemia, hypertension, glucose intolerance, and prothrombic and pro-inflammatory states. This is all considered metabolic syndrome. And ATP III places great significance on this because it's one of the major underlying causes of diabetes. And if you remember from ATP II to ATP III, diabetes was elevated to be a coronary heart disease equivalent. So, it's all interrelated and makes all perfect sense. If you've got one, you probably have the other. There's a couple of approaches to treatment. You can modify the root causes, which are, you can work on patients to reduce their weight and, try to work on the obesity, increase this physical inactivity, etc. So you can work on this, or you can directly treat. You can get out your pill box and you can treat them for these things. And typically what we mean by directly treat is with drugs. This is important and it's a little complicated. It's nothing simple. For individuals who are considered high risk for a coronary artery plaque rupture or a coronary artery event that I mentioned within a 10-year history is considered high risk, and we treat. Consider it high risk and we treat because we don't want anybody to have an event within 10 years, okay? So this is going to play into your how you factor in who you're going to treat and how you're going to treat them. We also have a risk factor of 0 to 1. It means that the 10-year risk factor for coronary heart disease is less than 10%. And so therefore an LDL goal of less than 160 is acceptable. So here's your exception to the rule. Remember I said I could make it easy for you and just say the optimal level for an LDL is 100? Well, if a patient is young and healthy and say, you know, they have nothing except this LDL, ATP 3 is saying that less than 160 is okay. Okay, you don't, because of the 10-year risk factor. So I guess the point of this is, you probably can't remember this, so you're going to go to charts, and you're going to look at the charts. But I guess the point of this is, we have to figure out who's at risk within 10 years and who isn't, and then it kind of motivates us. You take that, the risk with what their lipid panel is, and figure out how you treat. Long-term treatment, I said for patients who are older and not considered high risk for a cardiac event. I mean somebody that's older and stable, and they're going to have more than a 0 to 1 risk, okay? And you're going to be treating them over the long term versus a short term, okay? Because the goal is to slow it down, or slow down the progression. We manage it as a cardio heart disease risk equivalent. Now, diabetes type 1 is interesting, and it's determined by clinical judgment. So just because someone has diabetes type 1, it doesn't necessarily mean they're a coronary artery disease risk factor. We're talking about diabetes 2 here. Now, the thing about diabetes type 1 is, as you know, these people need insulin, and the etiology of this is very different than the etiology of this. And these patients, if they're just brand newly diagnosed, they're not necessarily, the day after they're diagnosed, they're at a high risk for coronary heart disease and going to have an event within 10 years. However, if they've been diagnosed with diabetes type 1 for a long, long time, they're probably having some end organ damage signs, if you will. And so therefore, you may want to treat them as a coronary heart disease risk equivalent. And you get to do that if you want, because that's up to your clinical judgment. Okay, we've talked about this, the risk factors. LDL lowering therapy should be adjusted to the individual's absolute risk for coronary heart disease. If we didn't have to take this and factor in the risk factors, we'd just probably treat everybody less than 100, right? Everybody less with a high LDL, and try to get it down to 100. But no, they have to make it more difficult to remember. The 3 established risk categories are those patients that already have established coronary heart disease. They have angina, they have atherosclerosis, they have high blood pressure, they've had an MI in the past, they have TIAs. And then those who have like diabetes are going to be lumped right in there with these folks. That's what we mean by risk equivalent. Multiple 2+ risk factors. They might be a smoker and they may be obese. So there you go there. And then a 0 to 1 risk factor. So these are the 3 that we're typically using. And high risk is those in, and some of this is like greater than, if it's within 10 to 20% in 10 years, it's definitely high risk if it's above 20%. 20% chance that individuals are at chance for a coronary event within 10 years. But 10 to 20% is also high risk as well. And then this is where I told you get to subtract a risk factor for HDL greater than 60. Yay! Let's see. These are the people established CHD, which I just went over. Oh, and I forgot, history of coronary procedures. Someone says, no, I've never had an MI, but say they've gone in and they've had a stent because they've had chest pain, or say they've had, I don't know, they've had some sort of procedure. They're at CHD, equivalent risk factor, if they've had an angioplasty or coronary artery surgery. The risk equivalent, peripheral artery disease, abdominal aortic aneurysm, cardiac artery disease, TIAs, I already told you the stroke, greater than 50% stenosis on ultrasound or angioplasty of a coronary artery, if you will, renal artery disease, and this. And then your multiple 2+ risk factors, okay? Another thing, if you think they might have an event, they're within 10 years, greater than, they're high risk. They're a smoker, they have high blood pressure, they have low LDL, They have a premature history, family history of a cardiac event with their father died at age 40 of a massive MI, and the patient is, 60, 65 years old in a male, or, 70 years old in a woman. Then they're positive for 2+, 3+ risk factors. Okay, so the LDL goes for these 3 risk factors. CHD and equivalent, less than 100. So these are the people we go after, okay? Multiple 2+ risk factors. ATP III guidelines are saying, in some circumstances, it's okay. I mean, institute your lifestyle changes. There's a big push on instituting therapeutic lifestyle changes, and we're going to get into that. They don't want you to run to medicines. And the reason is because it's costly. Patients don't have the money. It costs, insurance companies, on and on and on it goes. And they say a large majority of the population has, say, a cholesterol between, an LDL cholesterol between 100 and 130. And they feel like 80 to 90% of our society would be on lipid-lowering drugs, and they say that's excessive. So they're giving wiggle room to these people that, they don't necessarily have to be on drugs in some circumstances with an LDL less than 130. And see, here it is again. Say the patient's young and the only risk factor they have is smoking. Well, say they smoke as a risk factor, and that's it. Their LDL can be less than 160. I don't know if I agree with that, but... Or say their one risk factor is smoking, and yet their HDL is 65, so it's greater than, you get to subtract, so they have a zero, subtract a risk, you have 0. So I don't know, but that's what I'm telling you what the guidelines say. 2-prong approach to treatments: manage the LDL, and then manage the metabolic syndrome and other risk factors. Okay, therapeutic lifestyle changes. All right, they're big on it. And I have really nice little charts for you in the end of this lecture, so you can look at them and go, oh, I worked hard on putting them in. You're going to talk to these patients about decrease of intake of saturated fats and cholesterol. You are going to know what your dietary options are to enhance LDL lowering cholesterol, such as your plant stanols. And I don't particularly care for this because there's a CAGE questionnaire as well in assessing alcohol abuse, as you probably know. Have you ever thought about cutting down on your drinking? Has anyone ever been annoyed by your drinking? Do you ever feel guilty about your drinking? And do you ever need an eye-opener in the morning? Okay. Well, here we are now in the ATP III guidelines, and they have a CAGE questionnaire or assessment for assessing patients' intake of saturated fats. So this is, I think this is good because it's a quick way to assess where the patient is at as far as intaking of saturated fats and cholesterol, and we'll review it. So you might say to them, they might not know what foods are in cholesterol. They may not know the difference between saturated and unsaturated fats, good fats, bad fats, etc. So you ask them, well, how much cheese do you eat? And you can also ask, do you drink whole milk or 2% milk? Do you eat a lot of ice cream, cream, whole fat yogurts? Quick assessment right there. I mean, that's going to give you some idea, okay? Animal fats. So A stands for animal fats. Hamburgers, hot dogs, bologna, salami, sausage, fried foods. Anything really that's like Italian in nature. The prosciutto, salami, all of that good stuff. That's animal fats. G means got it out of the home. Fast food, that should say restaurants. Okay. And eat extra is the E, meaning you ate pastries at work today, someone brought in donuts, there was a candy dish on the secretary's desk, eating extra stuff that you necessarily don't want to eat. You can look at their weight. You can look at their BMI. You can ask them if they're interested in lowering their weight and yada, yada, yada. Okay, assessing weight control. ATP III recommends we encourage moderate physical activity. And it's in the book what we consider moderate, but you know what? I say, 30 minutes out walking every single day. I stick by my guns. If you tell patients they only have to exercise 2 to 3 times a week at 30 to 40 minutes a day, I think we're doing a huge disservice to them by giving them permission to not exercise the other, whatever days, if that is 4 days. No. I want them out there every day doing something, and I tell them, highly encouraging in that. It doesn't have to be at the gym. It doesn't have to be on the treadmill. Just walk around the block. Walk your dog. Walk with your spouse. Why don't you connect that lust that you once had, and then then walk around the block and add a half a block to it, and then walk around. Now you're up to 2 blocks. And I try to encourage them also by saying, hey, I have had very successful patients, and you guys can say, since I've told you, that you know of individuals that have lost a lot of weight just by walking 30 minutes a day. And, doing a few other little things, but we're really motivated to lose weight. And it works. And then at any time you can consider referral to a dietitian. And that's going to depend on your clinical practice. Are you really, really busy? How much time do you have? Do you have an awesome dietitian? Do you not want to deal with it? Refer. Okay, I put MP responsibilities for visit number 1. The patient comes into you, all right? And let's just say they come in for, I'm worried about my cholesterol. Well, what you want to do is do a quick lipoprotein evaluation. Well, you just did that with the CAGE dietary questionnaire. Now, risk factor evaluation. Well, I already told you what the risk factors are, and that is nothing more than you doing your health history, your family history, your smoking, your alcohol, and then tick it off. How many risk factors does this patient have? Alcohol, smoking, they have high blood pressure, that's a risk factor, positive family history, of course, all right? So you evaluate. Well, you assign the risk status, okay? And I get into that, I think, a little bit more here. And then once you assign the risk factors, which means, are they at risk for having a coronary event in the next 10 years of 10 to 20%, okay? Either way, control the risk factors if you can, reevaluate in 1 to 5 years, okay? Or initiate therapeutic lifestyle changes, okay? It's your first visit. You may have to stick right into drugs here, but that's going to be pretty rare. Okay, patients have a coronary heart disease already established, or the coronary heart disease equivalent, diabetes type 2. You draw a lipid panel. So that's kind of why up here too, lipoprotein evaluation. That's why I'm kind of expecting that patient comes in, you draw a fasting cholesterol, a lipoprotein panel. You don't have the results of that yet. Okay, you're not going to get the results of that until a few days. Patient's long gone. So you can't really do much except to kind of do this and bring your patient back for the results. All right, first thing you do is you look at the LDL. LDL less than 100, fabulous, okay? But they already have coronary heart disease. Okay, so you can't just do nothing, even though that's wonderful. Okay, they're at pretty high risk. So you're always working on their therapeutic lifestyle changes, and you're always trying to control those other risk factors. You're sending them the dietary counseling. You're sending them to smoke, no smoking, etc., etc., etc. And and you're monitoring these people. Okay, LDL in between here of 100 to 129. It's therapeutic lifestyle changes, controlling risk factors as well, things of that nature. LDL greater than 130 in a patient with CHD and equivalent, you're going to also do your therapeutic lifestyle changes. You may want to go to LDL lowering risks because they're at high risk, probably for a coronary event, and the LDL is not less than 100, so they're at high risk there. You may want to go right to drugs, okay? If you go to the drugs and you say put them on a statin and they come back and they're lowering their LDL, okay, you can decide what you're going to do at their at that point in time. Multiple 2+ risk factors with a 10 to 20% risk for an event within 10 years. You want to see their LDL less than 130, okay? Because it's between 10 and 20%. The LDL is lower than 130. They're saying control other risk factors and follow up in a year. LDL is greater than 130. You still have to do your therapeutic lifestyle changes. And if their LDL is less than 160, after that, you can continue TLC. And if it's greater, you can consider adding drugs. It's kind of confusing, isn't it? Okay, now this just means that their risk factor is less than 10%. They're not at high risk for a coronary event in 10 years. So you see, less than 130, fine, no problem, see you in a year. Greater than 130, let's do the TLC. And they're also saying if it's greater than 160, you can, you know, but it says consider. See, they don't want everybody on drugs. All right, well, let's switch to the drugs. There's 4 major categories, okay? There's your HMG CoA reductase inhibitors, or commonly known as the statins, wonder drug, bile acid sequestrants, nicotinic acid, or niacin, you'll hear it called, and fibrates. Goals of therapy: lower the LDL. Statin, #1 choice. Okay? Now, the appropriate time to reevaluate whether your drug is working or not is 6 to 8 weeks. There is absolutely no sense in drawing another fasting lipid panel so you can get your LDL sooner than that. All right? So that's something important that I expect you to remember. If your goal achieved, wonderful. Keep the dose the same. Fabulous, okay? And they still need to work on their therapeutic lifestyle choices, okay? If their goal is not achieved, you have 2 choices. You can increase the statin dosage or add another classification of drug. Statin drugs are your most effective and practical drug to decrease your LDL cholesterol. This has been proven by 5 major clinical trials over a 5-year period. And it has proven this, that statins, lowering the LDL, lower the coronary heart disease overall, and also decrease mortality. Now, you need to tell your patients to take their statins at night. And if you do that, you're ahead of the game, because cholesterol is made at night. And statins have a very short half-life. So if you want your statin to get on board and to get through the liver where cholesterol is made, so less cholesterol is made, you want it to be in the evening. Okay, now this is true with lovastatin, pravastatin, simvastatin, and fluvastatin. Okay, now I was just talking to my sister who has been on a statin for a long period of time, and she's on pravastatin. And I asked, you take it at night, right? Oh, I think I'm supposed to, but I never do. I take it in the morning because I can never remember to take it at night, and all of my other medicines are due in the morning. So I told her to talk to her primary care physician about that, because atorvastatin has a longer half-life and is the only statin that may be given in the AM because of the longer half-life. So it's okay because it's going to cover you through the night. So, you know, if that's cost prohibitive, you know, oh well, take, because my sister's not paying for a more expensive drug. Her choice is going to be, all right, I'll take it at night. I mean, there's got to be, you know, a push here for her. But she didn't realize that this is why she should take it at night. So explanation is needed with patients. Do you believe that? Look at that number. Cholesterol is overall reduced by statins 18 to 55%. And statins are a well-tolerated drug. Okay, LDL cholesterol is reduced. I don't have the number there because it's reduced big time in through these numbers as well. When you have a patient on a statin drug, the HDL cholesterol is typically increased by 7 to 30%. Awesome. So see, a statin not only lowers your LDL, it has an effect on your HDL. Perfect. It also reduces your VLDL, meaning triglycerides as far as that, and we like to see that low. All right, now look at this. If you double the dose of a statin, you're going to expect your drop in cholesterol of approximately 6%. So I'm going to show you probably with the next slide or so. That's not that, you've got to factor that in. If the patient only has 6% to go to be below LDL, and you can keep the drug the same, meaning monotherapy is awesome and is the key, and you need to only increase their statin dose, say double it, their monotherapy, they can take it at night, no problem, and 6% is perfect, you can go ahead and double the dose of statin. However, I'm going to show you later on where you may want to choose another classification of medication instead of doubling the statin dose. Now, issues with statins. This is very important because increased hepatic transaminases have been known to occur when you start a patient on a statin drug. So when I told you back there was secondary hyperlipidemia, and I recommended, recommended there that you may want to get an ALK phosphatase, because it will point, if it's abnormally elevated, it'll point the way to some sort of biliary process or disease that's going on. I would just do a regular liver function test panel myself. To get the panel, it's easy. It's usually part of your, your chemical panel, and it is going to give you your ALT, AST, your bilirubin, your ALK phosphatase, and then you've got a baseline for these patients of which to work through. Now, if you haven't had your liver function drug test lecture yet or whatever, the way I remember hepatic trans is the S, manases, AST, okay? If the AST, there's AST and ALT, well, how do you keep the two apart? If the AST is really elevated and the ALT is normal, what can cause us to elevate is alcohol, S for statin, okay, and T for something else, maybe triglycerides, but S, AST, statin, okay, so that's easy for you to remember. And you're going to get this raise in this AST from the statin in a very low percentage of patients that you treat, 0.5 to 2%, okay? Now, a study by Bradford was done in regards to increased AST levels with lovastatin, and it showed that the AST elevations are dose-related, meaning if you have an AST level of 0.1% with, say, a 20 milligram dose per day of lovastatin, he proved that if a patient was on 80 milligrams, so he had some with 20, some with 80, and it was 1.9% for all of these patients. So those that got elevated due to a statin drug of his study of lovastatin did show that it was dose dependent. Although progression to total liver failure is rare, thank Lord for that. But having said that, you still need to follow the AST levels because you don't want it to be your patient that goes into liver failure and ends up on the liver donor list because you prescribed a statin, doubled the dose, maybe tripled the dose, never drew liver function or an AST level, didn't keep your eye on it, didn't monitor it, your host, okay? So keep this in mind. You must follow the AST levels until they return to normal or stay the same, okay? If they return to normal, great. If they stay the same and they're really low, you can probably be all right with that. You may want to consult with someone, hey, is it okay, this is what happened, but it's just this level and it's really low, what do you think? They'll probably say it's fine. But then I document that. All right, but if the AST levels increase 3 times, okay, now this is ATP guidelines again, the upper limit of normal, discontinue the drug. Okay, so don't forget that. And 3 times the upper limit, that's dependent on your lab. All right? This I don't understand, okay? However, I didn't really research it significantly, so if anyone would like to do that, that would be nice. But they say if you stop their statin and their LFTs return to baseline, and say they have good reasons why they can't take the other classification of medicines, if you select another statin, they say typically there's no rise in the AST level with another statin. And I don't know why that is. All else I know is that's in the guidelines. You still have to monitor it, but I thought, well, I don't know exactly why that is, but I'll pass that on. If a patient has a history of cholestasis, okay, gallbladder, and active liver disease, it's contraindicated to prescribe a statin drug. So you got to make a good history. Hepatitis B and diagnosis of hepatitis C. They're unsure, the research is unsure how the statins can contribute to this or aggravate this or not. All right. Myopathy is well established with statins. So this is the big side effect. Okay, this and this are the things that you worry about when you prescribe statin drugs. And an increased creatine kinase is the best indicator of statin-induced myopathy, because patients, if you tell patients that they need to keep an eye on their urine and they need to notify you of any brown urine, they may ask you why, and then you can say, well, side effect of statins, sometimes it's muscle aches and pains and myopathies and overall, generally, and they come in and generally they all, some people just, you set the seed and they get the side effect. And they come in, you need to draw a creatine kinase, okay? Because it may be associated with statin, and it may not be. That's your diet, that's what that is. Myopathy is characterized by muscle aches, soreness, or weakness. It has to be an increase in your creatine kinase levels by 10 times the upper normal, all right, for it to be, okay, they're complaining, and it's this, definitely discontinue the statin. Failure for us as NPs to recognize myopathy and continue the drug therapy can lead to rhabdomyolysis, breakdown of muscle tissue, myoglobinuria, meaning, you're breaking down muscle, you're breaking down protein. You're breaking down protein, you're going to pass it through the kidneys. You pass these large cells through the kidney, you're going to get acute renal necrosis. Okay? You got to remember, proteins are very large. That's why you do not want high proteins in your diet, because these people go into renal problems because you can't clear high amount of protein through your kidneys. It's too much of a stress in your kidneys. However, the guidelines do not recommend routine monitoring of creatine kinase levels, because I guess the incidence of myopathy is very, very, very small. It's just not cost effective. There's another classification of drugs called bile acid sequestrants. These are two of them, cholestyramine and cholestyramine. Now, both of these drugs, they come in powder form, and which it has the patient's choice if they want to mix with water or juice. It's usually given twice a day with meals. These drugs are a pain to take, because if they need to be taken 1 hour prior or 4 hours post meals for them to work most effectively, and they're bulky. All right. Now, the tablet form, cholestyramine, is a more potent sequestrant, and can be taken with other drugs. I can guarantee you it's more convenient. It's going to be more costly for your patients. It's probably not in half the formularies, because hospitals, etc., are trying to reduce costs. If these were just as better for less cost, they don't necessarily care that it's inconvenient for the patients to take, because they don't want to go broke. There's a pharmacy budget. Bile acid sequestrants lower LDL cholesterol. They remain unabsorbed through the GI tract, and they lack systemic toxicity, so they have a pretty safe chemical profile. There's two disadvantages, however. Because of their bulk, they lack convenience of administration, and they cause GI issues such as can be constipation, bloating, fullness, flatulence, and nausea, because they're flying through the GI tract and you're not going through your normal absorption of your food intake. How they work is they bind bile acids in the intestines, and when bile acids are bound, there is a decrease in the hepatocyte cholesterol content, which lowers the LDL cholesterol. Remember, I told you that cholesterol is made in the liver, and that we need lipids, because lipids make bile acids and steroids. It's one of the very first charts. So anyway, sequestrants will bind these bile acids. Okay, so that's how they work. Sequestrants are really good to add to a statin to enhance effectiveness. And this is what I was saying I would talk about. I already went over why doubling a statin dose, you're going to get 6% decrease in LDL, and that's great if they only need to be reduced their LDL by 6%. However, look at what happens if you add a sequestrant to a statin. Instead of doubling the dose, you get, look at this, an LDL level reduced by 12 to 16%. Well, how bad are these people off the chart? Because like I said, it's inconvenient, it's bulky, and if they can't tolerate a bile estrogen, they can't tolerate it. So then you're going to double the dose of a statin. Or you might try nicotinic acid as well. However, look at that. That's pretty nice. And also note that sequestrants will raise triglyceride levels. So that's not good, okay? We don't want triglyceride levels raised. So if the sequestrants, if your triglycerides are greater than 400, they're contraindicated. Okay, third classification of drugs is nicotinic acid or niacin and fibrates. Okay, the two nicotinic acids are the crystalline and niaspan. So I say this up front so you know what I'm talking about. And fibrates, you've heard of them. Gemfibrozole, fenofibrate, and clofibrate. Let's talk about niacin. Niacin will lower your LDL, your VL, that's spelt wrong, VL, very low density lipoproteins, VLDL. They lower your triglycerides and they increase HDL. Well, what's wrong with that picture? It's perfect. That's exactly what we're looking for. However, niacin is dosed 2 to 3 times daily, so a statin's once a day. Typically, 2 or 3 grams daily are needed to reduce the LDL by 15% or greater, so that's pretty high dose. All right. Crystalline preps are inexpensive, but this is a huge side effect of flushing. Patients get the cut flushes, and you know people don't tolerate that. So this is important for you to ask. This is important for you to tell the patient that I'm putting you on this, and some patients experience face flushing. Tell them to stick with it and see if they can tolerate it, because flushing does reduce after a period of time. Okay? So, if they're getting, it's low-cost medicine and they're getting a good bang for their buck, see if they can stick it out. Try to give them the lowest dose possible so that they don't have this, and then you don't have to change the drug or make them go off it. Niacin works directly on the liver to decrease cholesterol production. And actually, say your lipid panel looks pretty good, and the only real thing that you need to work on, and sometimes that's the case, sometimes the LDL is less than 130 in an appropriate patient for it to be less than 130, but the HDL levels are horrible. They're like 10 or 15. And you don't necessarily, you could put them on a statin, but maybe you just want to get the HDL levels up. Well, this is the perfect drug for you to use for that. Okay? And sustained release niacin is noted to have less hepatotoxicity and less flushing. Once again, probably more expensive, probably not in your formulary. Okay, and these are your fibric acid derivatives. These are the last 4. This is the 4th group that you can use. It's a very complicated mechanism of action. It works very well to decrease triglyceride levels. It only has an LDL lowering typically of 10%. Your statins and other drugs are better than that. So you don't go to this first at all. It's used primarily to lower your triglyceride levels and prevent pancreatitis. So this is very appropriate for hypertriglyceridemia. It's excreted in the kidney. So, fibrates and Coumadin are a no-go. And, you're going to get some pearls through me throughout my teaching in the course. And if your patient's on Coumadin, you look up everything you're going to prescribe to see if it goes with Coumadin. So if you remember anything from Margie, if they're on Coumadin and you're thinking of prescribing something, you better look up Coumadin and see what's a no-go, because the list is a mile long. Okay, let me see. Risk versus therapeutic lifestyle changes with or without drugs. Okay. 10-year risk, the LDL goal, therapeutic lifestyle changes, everybody, and then drugs, when you introduce drugs. So this is a pretty good slide. Great 10-year risk greater than 20%, high risk. We want the goal to be less than 100. Okay? If with your therapeutic lifestyle changes, your goal, if your level is 100 or greater, you institute therapeutic lifestyle choices. Okay? And if these people are usually the coronary heart disease and coronary heart disease risk equivalents. It depends on how high this is before you put the patients on drugs. Okay? High risk, less than 130. The goal is less than 130. They're greater than 130. Okay? You're doing your therapeutic lifestyle changes here, and then you can also introduce drugs if you want. These people probably are on drugs too. Your CHD and CHD equivalent. I'd have them on drugs. They're high risk, greater than 20% of having a coronary event. I'm not messing around. I'd probably cover them with a statin. Here you go. You can cover these guys with a statin. Now, less than 10% is low. All right, the LDL is, you got wiggle room on this now. They're saying it's low risk. If we had everybody, treated on drugs that has an LDL of between 100 and 130, we'd have 90% of the population. So they don't even, if they're greater than 130, you should institute your lifestyle therapeutic changes. You can start drugs if the, if the risk, if the LDL is greater than 160. Multiple 2+ risk factors, same here. You can put them on start drugs greater than 160. And look at this, greater than 190 on a 0 to 1% risk factor with a low risk of a cardiac event within, 10 to 20 years. The LDL goal isn't that high to start with, and if it is greater than this, they're saying TLC. You don't even, here, I'd started a lot earlier than that, and you can institute drugs here. So there you go. There's your chart. Keep that in your armamentarium, and when you have a place you're unsure whether to treat or not, you got it. Okay, I need to pause here for a minute and take a sip of my tea. Well, I hope I'm on again and continue recording, but oh my gosh, this feels like this lecture's taking forever. Okay, a little bit on diet. Okay, I pulled it out of the ATP guidelines. I had kind of had a lot of fun with this myself because, we all think we know. And then you get out there in clinic and a patient asks you a question of what's high in this or low in that. And it's like, I totally have to look it up because I blank a little bit. But you want a total fat, I'd write this down. You want a perfect balance of, you need fats, you need carbohydrates, you need protein, and you need dietary fiber. You need all of those things, okay? You definitely need fat, carbohydrates, and protein to live, okay? So between your fats of polyunsaturated and monosaturated fats, your total fat in your diet, total calories should be 25 to 35%. Most people guess it should be way lower than that. Not necessarily, but it depends on what kind of fats you're taking in. Carbohydrates is the highest. Most of your calories, 50 to 60%, so half, should be carbohydrates because they break down to simple sugars. Now, there's good and there's bad. There's high bulk and low bulk carbohydrates, and protein should really only be 15%. That's why the Atkins diet is not very healthy when all you eat is protein all day, because you're putting your body into a ketotic state, okay? You're depriving your body of some precious nutrients and calories, etc., and then you're spilling protein in your urine. And when you do that, you're going to put yourself into some sort of kidney problem. So dietary fiber is very, very good, and we want a lot of it. I don't know exactly 20 to 30 grams a day, but we want a lot. The increase the fiber, the better off you're going to be. But we do this in steps, typically with our patients. Major sources of fat, in a nutshell, if the patients ask, whole milk, cheese, butter, ice cream, cream. Okay, easy. Meats, palm oil, coconut oil, baked products. I think we know that. Stay away from the trans fats. We don't want to see them. they're in crackers. You want to see trans fat free. Stay away from the trans fatty acid free in our margarines. You want to stay away from butter, so they say. Cholesterol, eggs, high fatty meats, high fat dairy, and plant stanols and steroids are good, and we want them in our for soybeans, and we add this later with the what do you call it, fiber. Sources of fiber are cereals, grains, fruit, legumes, okay, hummus, chickpeas, vegetables, broccoli, Brussels sprouts, and carrots. All right, there you go. This is a summary slide. I'm excited. All right, we've talked about high cholesterol. We've talked about especially LDL, and we know, and I have shown you why we know, that LDL cholesterol is directly linked with coronary heart disease. LDL cholesterol is the target. We want to see it less than 100, optimal, in all patients if we can. And HDL, we want it high. We like HDL cholesterol. It's cardioprotective. The higher the better, and we'd love to see it greater than 40. All right, the complicated piece to this is identifying the patient's risk factors for having a cardiac event within 10 years. All right, greater than 20%, that's 2 out of 10 patients, that's high. I would start your medicines. 10 to 20% of patients, the risk is still high, and I would typically probably start those patients on medications as well. Less than 10% is low, and you want to focus more on your therapeutic lifestyle changes. I'm going to add something, all patients need to be on therapeutic lifestyle changes, and you bring them in, you tell them what their diet should look like, you hit them with that CAGE questionnaire, you kind of give them a few ideas on how to change their diet. Exercise, if you want more details, go to the guidelines. I tell them to get out and walk 30 minutes a day, that's what I expect. They can keep a diary and a weight diary, and on subsequent visits, check their weight, check their BMI. How are they doing with their diet? Let me see your calorie book, or at least what you're eating, and see how they're doing. Because then, if you want to introduce more on diet, you can talk more into what the stanols are, how they're good for us, how they are a good fat, and soybeans, and then you can talk more about diet. In summary, drugs, think statins first for lowering LDL unless contraindicated, or you have a couple of those 2 side effects that I talked about, an elevated AST, which you are going to monitor through liver function tests, or they have a problem with, this is my last slide, or they have a problem with, what was the other thing? Whatever I said. Oh, AST and, myopathy. Remember that, and let me see. And if you're going after the HDL and the triglycerides first, which is going to be on rare occasion, check your, you might want to use your nicotinic acids or your niacins or your fibrates for HDL and triglycerides, and there's appropriate times to do that. So, I'm at the end. I'm sick of talking. Stephanie just walked in. That means, did I go over an hour? This is horrible. Bye. Nanu, Margie, checking off.